I think we can start now. We have several people logged in. Okay, very good. Good morning, everybody. We are very pleased to have in our conference today Dr. Legome. Dr. Legome is a professor of emergency medicine here at Mount Sinai and the chair of Mount Sinai West and Mount Sinai Morningside emergency departments. He has held many leadership positions, chief of service at the Kings County, chairman at St. Vincent's Hospital, residency director at NOU Bellevue, associate residency director at MCH. Dr. Legome has a strong clinical and research interest in traumatic brain injury, and he's actually a co-editor in one of the major textbooks in the field. And Dr. Legome is very well known to us from his very insightful and helpful comments in our trauma meetings. And whenever he talks, I'm always, my attention is 100% on him, and I always learn I always learn new things from him. So I think that we can start. And Dr. Legome, I pass the speaker to you. Dr. Legome, we cannot hear you.
Hang on a second.
Perfect.
Can you hear me now?
Yeah, perfect. Okay,
good. All right. I tried to get fancy and use a microphone. That clearly didn't work, so we'll just go back to the old style. All right, we're good? You're okay? You can hear me now?
Yes.
Yeah,
Okay,
you're good.
All right, in a minute, I'm gonna share my screen. I'm gonna ask if you can see it just to make sure this is not the usual screen I use. So if there's any problems, please let me know. The one caveat is I'm not sure I can see the chat. So if there's any questions anytime, just feel free to interrupt. It's fine with me. Will not hurt my feelings at all. And just go ahead and ask them. But if you put something in the chat, I may miss it during the talk. I'm not that savvy with Zoom, although I do believe I spend about a third of my life on Zoom, like probably you all do now. So first, thanks a lot for having me here. It's really great. And as mentioned, I spent quite a bit of time out at both Bellevue and at Kings County, and I'm very familiar with Elmhurst and had done a lot of work with some of the physicians there. So I know what a great place it is and how well you all do trauma. So it's really great to be able to have this with you. And one of the things I am going to talk about is when you look at all of the work that's been done in the pre-hospital and emergency field in emergency medicine, looking at early brain injury, a couple things come through. One is most of them don't work. And I was a co-PI at Kings County on the progesterone study in traumatic brain injury, and you realize these take an enormous amount of time and energy to get these studies through, and so it really is unfortunate that so many have failed, and for lots of reasons, mostly because the brain is very complex and there's multiple biochemical cascades going on at the same time when there is brain injury. But some of them probably do work, and some of them definitely do work, and I think that I would like to talk about them to make sure that we know about them, we're concentrating on them. And there's also a couple that are kind of maybe they work, and I will briefly go through some of the literature, and I think it's really kind of for us to understand what they are, why they might work, why they might not work, and then make some decisions of how we will incorporate them into our care. So with that, let me go ahead and try to share this. If you cannot see it, please let me know. Give me 1 second. And I'm going to make this big in a second. Can you see my slides?
Yep, we can see them.
Yes, okay, good. And I can see you. Hopefully you can still see me. So we're going to talk about some updates to literature and head trauma. What I've tried to do is stay, for the most part, within the last couple of years. But I do go back a little bit to try to get to here, just to talk a little bit about the progression. I do not have any financial relationships. As mentioned, I've been very interested in writing about trauma, whether it's textbooks, CME, some stuff for residents. And this is just some of the text I've done. Unfortunately, I do have no relevant financial relationships to disclose. I'm not sure these were the best-selling textbooks ever, but they do have a lot on brain injury, and hopefully people find them useful. And one of the things that I did do, especially in our trauma text, and this came out several years back, but it was a collaborative book, and every single chapter we did was written by an emergency physician and a specialist in another field, whether it be neurosurgery, ENT, et cetera, because I do see trauma as really a collaborative specialty, and what we do affects down the line, and how we interact really makes a difference. So once again, thanks for having me here. So I titled this talk, What Doesn't Work, What Might Work, What Could Work Better, and What Does Work, because I think there's a little bit of everything when we talk about head injury and some of the things we do. I'm going to talk about hypothermia. I want to talk about TXA a little bit about concussion sequelae, some stuff about adjuncts, and then touch on the EPIC pre-hospital study, which some of you may or may not be aware of, but I actually think it has some very important take-home points for how we treat head injury, both in the pre-hospital field, but also what we do in the emergency department. So I'm going to give you a very kind of common scenario. It took about 10 seconds to make this up because we see this every single day, it seems like, in the emergency department. You have a male, very commonly they're intoxicated, fell from a ladder onto a hard floor, landed on his head with LOC, had a CT with a subarachnoid and parenchymal hemorrhage. Patient is stable. We have consulted neurosurgery at that point. You've all seen this. You've all been there. So our neurosurgeon comes down, and we have lots of discussions about all the things we can do. We have, intubation. They're really sick, hyperventilate. Don't hyperventilate them. Anti-epileptics. Put the head of the bed at 30 degrees. Do hypothermia, although we don't really do that a lot in ED. TXA, whether or not to use it. Blood pressure. Damn it, that's important. Hypertonic saline, mannitol, etc. So there's a lot of things we can do. And one of the things that I see, and I think that it's probably consistent everywhere, is that both we do the same thing, is that we don't have always exactly the same thing we do for the same patient. So we can ask 3 different neurosurgeons, and we'll get 3 different answers. You get 3 different emergency physicians, you get 3 different answers. And I think that as we look through the literature, we'll see a little bit why. But I also think there's certain things we all really should be on the same page about. They're relatively simple, and I do want to highlight those. So the first thing I want to talk about is hypothermia. And the reason is that this has been in some ways a little bit of a holy grail with head injury. It has been around for at least 20 some years to see, can this make a difference? And like some of the other treatments, it's an enormous amount of time and effort and money, et cetera, expended in trying to make it work or understand if it works. So the first study, I'm going to go back all the way to 2001, is the NABIS, National Acute Brain Injury Study, where there was 392 patients. And what they did is they took severely head injured patients, and they essentially made them hypothermic, or tried to make them hypothermic. The idea is that if you use prophylactic cooling, you can attenuate cerebral inflammatory and biochemical cascades, which come on after traumatic brain injury, and then theoretically you'll limit secondary injury. So the first study, and this came on after some smaller studies, and there's actually a Cochrane out in 2017. I think there's been up to 2017, there's been 37 hypothermia studies in traumatic brain injury. So once again, a lot of energy has been put toward this. So in those patients, they took them and they made them hypothermic down to 33 by 6 hours, or they tried to get them by 6 hours. I think overall they were induced by about 4.5 on median, and got down by about 8 hours. And then over 48 hours, they kept them and then slowly rewarmed them. And unfortunately, given the literature prior to that, everyone was sure it was going to work, and they found that it did not work. However, there was one subgroup in there, those that were less than 45, who came in hypothermic and remained hypothermic, or randomized to the hypothermic arm. They did better, better mortality, better morbidity. So that was found. So NABIS doesn't work. But the next question was, well, since the ones that came in hypothermic they stayed hypothermic and they did better. There was a significant improvement. Let's go ahead and try to get people hypothermic faster. So there was the NABUS-2 study, which took place over multiple years and concluded in about a couple of years back. And what they did is they took patients and tried to randomize much quicker within a couple hours, and they found they were able to get them down within about 2.5 to 4 hours. And what they did is they got them down to 35 degrees. They looked and said, is there any other trauma we're missing since we're doing this so quickly? And if not, they got them down to 33 degrees and kept them that way for 48 hours. And unfortunately, what they found in there again is it did not work. Now, is anybody, I don't know if anyone's familiar with Guy Clifton. He was the neurosurgeon. He was the head of neurosurgery, I believe, at Houston. And this has really been, he was the hypothermia person. This is him here. And after, I actually looked him up to see what happened. And after that second study, I think he had enough of it. He now runs an insurance company. So I think the hypothermia, it was thought, probably just doesn't work. But then in 2018, there was a big meta-analysis done, and they felt based on that, there was some evidence that if you got them down really, really quickly and kept them down there for longer, you may actually find a difference. So that led to the polar RCT, which I'm going to talk about in 1 second. Just as a kind of sidelight is you have the Eurotherm 3235 study with about 400 patients. And that was looking at a little different question, was if you take patients who already have high intracranial pressures and you make them hypothermic in the ICU, does it help? The idea is that you will bring down the pressure with that and ultimately they will do better. Unfortunately, it does help. It does get your intracranial pressure down, but what they found, it actually kills people. So the question of, can you take patients who are already with increased elevated ICP and make them hypothermic, once again, doesn't work. So briefly, the polar RCT, this came out in, I think, late 2018. I do think this finally put a nail in the coffin of hypothermia. But the question, so what they did is they took about 500 people with severe TBI in the field. And, looking at the question of, can you get them cold faster? They actually started super cold, I think 4 degrees, normal saline, both in the field and immediately on arrival to the emergency department. They left them exposed and they put cold wraps on them. So they got them down really, really quickly. And this was done, as I said, in 6 countries, multiple paramedic agencies. I forgot exactly how many. I think there was over 30 or so. And it was 500 patients. It took about 5 or 6 years to do this study. So what they did is they randomized the patients and they got prophylactic hypothermia. They got them down very, very quickly. I think the median was about 1.8 hours. And they kept them down there. They kept them down there for at least 72 hours. And if they found they had high ICP, they kept them down later up to 7 days and then they gradually rewarmed them. And the primary outcome was, how did the patients do based on the Glasgow outcome scale, which is, as you know, is a very common and appropriate scale looking for ultimately how patients do who are discharged from the hospital. With the lowest ones, with the, if you look on the far side of the slide, in the gray and black, they did not do well, so they were under 5. And in the kind of the brownish ones, they did well or above 5, and they had lower and moderate disability, good recovery. And ultimately, they found that there was no difference. And so when you look at all of these different options, going from cooling them down relatively quickly, cooling them down faster, cooling them down very quickly, leaving them down for 48 hours, slowly rewarming them, leaving them down up to 7 days, slowly rewarming them. All of these failed. And so I put this in because this is just one of the many really extensive studies and work to try to find things that work in traumatic brain injury. And this is over a 20-year period it took, and ultimately it just doesn't work. It's unfortunate, but thought it'd be worthwhile thinking about this and just taking a look at that. So let's move on to something that maybe works. TXA and head injury. This is something that there is a lot of I would say a lot of controversy about, a lot of arguments about. I would probably argue that the controversy may not be worth it, because even if it's not, there probably is pretty low downside to it. But I think it's worthwhile at least looking at. So this came out in 2019. So for those who knew CRASH 2, this was a very large study with about 26,000 people that came out in the mid to 2015 or 2010, I believe, looking at patients who had traumatic injuries that may or may not have been bleeding. And they gave TXA a gram and then a infusion to, and found that there was a significant improvement or decrease in death. And there was a group of them that had isolated traumatic brain injury, although that wasn't the group they were particularly studying. And those that had isolated traumatic brain injury seemed to do a little bit better. So the question was, if you take TXA and give it to people with isolated head injury, how do they do? Do they live? Do they die? Do they do it at a different rate? And briefly, tranexamic acid decreases or helps block plasminogen to plasmin, which will break down a fibrin clot. So I would be interested very quickly, is there anyone, do people use it routinely or not at all, or some do, some don't? Any thoughts? No?
I can say, yeah, I'm not sure if we have the ability for people to say, but if they can put into the chat window whether or not they do or not. I know at Elmhurst, we've started using it more frequently. I kind of agree with you that the overall data is a little bit underwhelming, but it also seems to show that there's not much downside, like you said. Like all the negative effects that we are always concerned about don't seem to play out in the larger studies. So I started using it more just because there doesn't seem too much downside.
Yeah, I'll talk a little bit about what they said. When you read the study, it comes out as this is the new great thing. And then when you really read the study, you're like, well, maybe it is, maybe it isn't. But the same thing with just in general trauma. And there is, besides the CRASH, there's another big study called MATTERS, which looked at, it was a military study looking at TXA, and they actually had a significantly even higher improvement in mortality when they used it, and they were sicker patients. But you have these little studies that come out every couple of years saying, well, it doesn't work, we couldn't find anything, and maybe it's a little worse. But when you look at the better studies, they suggest that there probably is a benefit for those patients who are at least severely injured and get it early. But then here's a question, about CRASH 3. And really this was in people waiting years for this. And when I look at it, it really is, once again, an impressive study. There's over 10,000 patients in it. So this was done took them 7 years to do it. I think it was done in 175 hospitals and in I think it's 29 different countries. So 7 years, 175 hospitals, greater than 12,000 patients. So the inclusion were patients with a GCS less than 13 on arrival, or if they came in with greater than 13, but they did a CT scan and found blood, those patients could also get into it. And they put mild as 14 to 15, moderate 9 to 13, and severe greater than 9. The initial plan was patients got into it if they had a injury and they were enrolled within 8 hours. Somewhere in there that was changed to 3 hours, and part of that was from other studies showing that if you give it over 3 hours, there probably is a downside to it. There's probably a higher mortality. It's a complicated reasoning why. It does kind of make sense, and it has to do with the whole combination of the cascades and what comes out when. They excluded patients with a GCS of 3 or bilateral fixed pupils, which seemed appropriate because there's probably not much you can do will make a difference. Although with unilateral, they did not, which people argue that they should have. Major extracranial bleeding or less than 16 years of age. So if they gave a gram of TXA bolus and an 8-hour infusion, and they looked at head injury related death within 28 days and patients treated within 3 hours of injury. And this is kind of the big picture. So if you look at the different groups, on the left side of the screen, far left, you have mild and moderate GCS, and then you have severe GCS. So the very quick, easy one is those patients with severe GCS, and you look at it with the confidence intervals, there really was no difference. It didn't make any difference whatsoever, and that's these people, once again over here. If you look at the mild and moderate, and once you get to about 3 hours, you find that there is no difference here. And if you look at the confidence intervals, but if you get before that, they actually see a difference. And if you look at the risk ratio, it's down to 0.58. And so if you look at the overall, if you take every patient in the study, which it was set up for, what you find is that they really did not find a difference. It didn't work. However, there had some post hoc analysis, and they actually planned this, so this is pre-planned, and they found that the patients who had mild to moderate, so a GCS of, I believe, 13 to 15, I'm sorry, 9 to 15, they did see a difference in those. With placebo 7.5 and then a 5.8 in the mild to moderate. So a small absolute, but a relatively large relative. So the take home, and I'm going to get to take home in just 1 second. This is some of the, this includes the CRASH 3 and the people from CRASH 2, but this adds a couple other studies. And it looks at some of the other things or some of the other studies with TXA, and looks at mortality, looks at expansion. You know, the question is, why does it work? And does it decrease expansion of the hematoma? Possibly. Does it increase rebleeding? Possibly, a little less likely. And the real concern is, does it add to thrombotic complications? So if you give TXA, do people have more complications, PEs, DVTs, et cetera? And the take home from that, including this study, is that it probably does not. So it probably is a safe drug. It is an inexpensive drug. So 2 of the reasons not to use it probably don't exist. So, you know, once again, does it matter? Are you going to hurt someone? Probably not. So getting down to the results. So if you look at what they said, what the study said, our results show that TXA is safe in patients with TBI, and that treatment within 3 hours reduces head injury related deaths. Patients should be treated as soon as possible after death. They said we have a risk ratio of 0.78 with a significant with significance and a confidence interval 0.64 to 0.95 for moderate head injury. There is you can go online and read 30 different articles and reviews and letters, and the other people say, well, maybe not, because one, you know, they started at 8 hours and went to 3 hours. But the predefined number they needed was 13,000. When they went to 3 hours, they couldn't get that number of patients. And so they actually didn't meet their predefined analysis or their volume that they needed for the study. So they didn't really do it right. On the other hand, I would argue that, you know, close to 12,000 patients is pretty reasonable. And people also argue it was a negative study. They didn't find what they set out to do. There was no statistical difference in the primary outcome of head injury death, TXA versus placebo. And the difference was in subgroup analysis only. And so I guess my take home, and this is where I think it really is dependent, it probably is useful to have some sort of system plan or some sort of agreement, is that I do think it's useful. I will give it generally for moderate head injury. I'm not sure that minor made so much of a difference, but it's probably reasonable. But for severe, I don't. And I think that, you know, just like Dr. Hickman said, the downside is pretty low. But I do think it should not be a standard of care, and there's plenty of reason or opportunity for argument there. And just as a quick, and I think this is with a lot of these patients, you know, why does it may work for some and some not for others, is that, you know, you have your low severity patients, your GCS of 15, who the vast majority are going to do fine, so it probably doesn't matter. You have those who are severe, and the reality is that it doesn't matter what you do with some of these, they're probably not going to affect it. And so the number that they had of intermediates was not as high as you'd like to see. And potentially if they had a lot more of patients who were moderately injured, you actually may see a higher difference. So with all that, my take home is that probably worthwhile, low downside, not expensive, and I think it's a reasonable thing to give. But like many things, I think it's one of those things that it probably is helpful to have a designated policy and agreement, because it's one of those things that, because it may not be that important, it may, you don't want to have that necessarily need to have that discussion for every single patient at the bedside. EPIC. So I do want to talk about this because I think this is some really useful take-home information. This is a emergency medicine pre-hospital study. It was an NIH-funded study that took place over about, I think, 5 or 6 years. It recently was published in the last couple of years. It's the Excellence in Pre-Hospital Injury Care Traumatic Brain Injury Project. So I said it's an NIH-funded. It took place in Arizona and had an enormous number of participants. I think there was like 11,000 paramedics and EMTs, and there was about 26,000 patients enrolled in it over the period of time. And what it did is essentially looked at, it was an observational study that looked at if you provide basic care. So number one, it started with what are the things that we know or we think hurt patients in the pre-hospital arena? So hypotension, hypoxia, how bad are they? How many patients have them? And if we put out a bundle of things to do for patients, which are really trying to avoid hypotension, trying to avoid hypoxia, and also, I think really important, when they intubated patients, trying to avoid hyperventilation. Because if you look back at so many of the pre-hospital studies on intubation of head injured patients, many of them, as you see, come out to say that if we intubate patients in the pre-hospital arena, they tend to do worse. And the reason, what is believed is the reason that is true is not because you're avoiding hypoxia, that would make sense, but because when they intubate those patients, they are probably hyperventilating them. So they had very, very clear protocols, and they had ways to make sure they did not hyperventilate the patients, whether they put something on the tubes to make sure that to count exactly how they were ventilating the patients. And so first they did a lot of kind of analysis, just looking at patients and what happened. And we all knew that hypoxia is bad, hypoventilation or hypotension is bad in the pre-hospital arena. But when you look back at some of the old studies that said, this is a bad thing to do, and look at some of the numbers, these numbers are actually worse. And partly they get a lot more patients in them, but partly when you look at how some of those old studies were done, some of them were before pulse ox, and so they said, oh, if the patient was cyanotic, they were hypoxic. Some of them were only done at arrival to the emergency department. Some of them that they had no idea, they looked at either hypotension or hypoxia or none of them, but not together. So just the take home of that is that overall their death rate in severely injured patients from the field was 8.2%. If they did not have hypotension or hypoxia, it was 5.6%, so pretty significant. They had hypotension only, it was 20%, hypoxia only 28%, but if they had both, it was 43%. And if you look at the adjusted odds ratio of death, once again, you're seeing the same thing, that if you have hypoxia and hypotension, there's a huge, huge increase in the death rate, but either of them make a big difference. And so, my take home of this is, one is that if you can avoid them, especially in the field or on arrival to the emergency department, it is a huge deal. And this is one of the few things that when I look at those patients that come in, that I always concentrate on is how do we avoid hypoxia? How do we avoid hypotension in those patients? And if they have one, how do you do everything you can to make sure you don't have the other one? So move to the next slide. And this is also a study where they looked at patients with head injury and pre-hospital blood pressure. And what they found is it's not just hypotension. We talk about less than 90 degrees or 90. It's really, for severe brain injury, it's really, there is no absolute threshold. So it's not a dichotomous. If they're less than 90, they're going to do bad. If they're 92, they're going to do fine. But it really is a continuous variable. And if you look at almost every number on the way down, the odds ratios change as the likelihood of death. So once again, it's, avoid hypoxia, avoid hypotension, but really avoid dropping the blood pressure in any way you can significantly for those patients. And if you look, clearly once you get below 90, it goes a lot more. But if you can avoid that, it makes a big difference. Now, these are pre-hospital, but I would argue that especially on arrival to the emergency department, there probably is not a huge difference in avoiding hypotension and hypoxia. And then the next question is, what can you do about it? And so they put this bundle together that basically looked at, for patients with any suspicion of severe TBI, based on the mechanisms, GCS, their examination, they tried to do a couple things. So one is they tried to maintain the SAT tried to make sure they did not hypoventilate them, and they used end-tidal CO2. They had a ventilator that counted how much they were, how they were doing. They made sure that they gave fluid, a little bit of fluid early on, up to 1 liter, in order to avoid hypotension. And they were really, they spent an enormous amount of time making sure that this was, one, followed, and two, that they trained everyone appropriately in Arizona for this. And you can look at the algorithm here, but this is, basically the minimal, the same things that we have in the emergency department available for this. And so what did they find? So if you look at their survival for severe TBI, for the odds ratio for severe TBI is that it doubled the odds ratio of survival improvement. And for intubated, it was 3 times. So they found a significant improvement of severe TBI patients, especially in severe intubated cohort. So their answer is it supports widespread implementation of the pre-hospital TBI treatment guidelines. I would absolutely argue that it is correct. This is the first really large, and once again, really large study, 26,000 patients, or over 21,000 patients with severe TBI, that they did find a difference. But I would also argue that there is some real take home for this in the emergency department, and knowing that the significant downside of hypotension or hypoxia or hyperventilation early on really does make a difference. And we really need to be careful about, one, getting patients intubated appropriately and quickly, getting patients, or trying to keep them from getting hypotensive on arrival, and really being clear that should be part of our algorithm. I threw this in because this is a little bit of something not related, but I think related. This is a study that came out in the last year and a half from New England Journal that looked at patients that were not TBI patients. They looked at critically ill patients in the ICU, but it does talk to something we routinely do in the emergency department, which is rapid sequence intubation. And it's always been kind of a absolute that when we do rapid sequence intubation in patients, that we do not bag them after we induce them, waiting for the medicines to take hold. The idea is that it probably leads to more aspiration in those patients, and there's a downside. So they challenged that dogma, and what they did is they looked at patients who were getting tracheal intubation, who were critically ill, and all things being equal otherwise, they found that if they did do bag valve mask during the period of patient is induced waiting to be intubated, they found that one is the likelihood of them becoming hypoxic was lower. The lowest SAT they had was higher, and ultimately it was a beneficial intervention. And when we talk about the fact that hypoxia makes such a big difference in those patients, while this study was not in trauma patients, this has changed my practice, and I'm much more likely, especially in patients who have borderline hypoxia, if I'm intubating them, I will do bag valve mask, even though it's one of those things I was taught you never do. I think it actually is, based on this, probably a perfectly okay thing to do, and potentially better, especially for the patients where it makes such a difference on. All right, moving on. So other stuff, this is an entire another talk, but one of the things I always found kind of interesting is all the things we routinely do in the emergency department with a lot of our patients. There's really not a lot of evidence that it makes a difference. We should be doing it this way. So for example, platelets, I won't go into it in depth, but this is a recent meta-analysis in Journal of Trauma. I actually I was a co-author on one about 5 years back that I think these 3 papers were in, and found that for patients who are on antiplatelet agents, giving platelets, it's not clear it makes any difference whatsoever. I think we found the same thing, 5 years back, and it's one of those things that I think we continue to routinely do, but there's still no one's really found any good evidence that it truly makes a difference. Repeat CT, it's one of those things that I think in some trauma centers, they have a very clear protocol for patients who have very small subarachnoids. And the question is, do they all need repeat CTs? It's a pretty small group, less than 10% that decompensate to HUM with the GCS of 15 and are not on or not on Coumadin. So, it is, I think, a good discussion. And can you just watch them clinically? Admission for small subarachnoids. There's lots of places that have very clear protocols, and those patients can often just go to an OBS unit and be discharged the next day as long as they're doing fine. So I think that, in the time of, resource utilization and trying to save beds, that may be, and I'm not sure if anyone does that over here, but that may be an option for some of these patients. They really don't need to be admitted for, a couple days or even to an inpatient bed. Seizure prophylaxis, I think we've changed for that. It used to be everyone, but I think we realize that it's not entirely clear how beneficial it is. And, now there's a much, from the Brain Trauma Foundation, there's a little bit different kind of a take on it that maybe not use it, kind of look at the downsides to it. And I think we could probably talk for about 2 hours on mannitol or hypertonic saline. But I think there's still no great answer. I think we use it as a last ditch, but how well it works and what it does, is one better than the other? Maybe HTS, but I think it remains unclear. So, and then, my favorite is the head of bed. It's one of those things that's kind of dogma. We need to put everyone at the head of bed of 30 degrees. If you actually look at the literature behind that, there really is no data that it makes a difference. Another one just came out, I think, in the last couple of weeks on pediatric severe head injury patients. And they took patients with monitors in them and they moved them up and down and found that 30 degrees was good on some days and 20 degrees or 0 degrees was better on other days. So once again, it's one of those things that's a little bit of dogma, but when we look at the literature and the evidence behind it, it's a little bit unclear. Does it actually make a whole lot of difference? I'm going to get into the last part. This is actually from some of my colleagues at Sinai. One of the things we do that's a lot of fun is we do the concussion evaluations for the NFL. Most of us work on the Jets at Meadowlands Stadium. So for those of you who like the Jets, it's been some terrible seasons, but it's a lot of fun. And what is neat is that the NFL has an enormous amount of data on concussions, and they are beginning to share a little bit more. And so it's interesting to see what they're finding out. But I think concussions are something that we probably could do a better job in the emergency department. So I just want to talk a little bit about traumatic brain injury and the sequelae, and a little bit about how we do it in the emergency department, or what we do well or don't do well in the emergency department. So very briefly, first study is, this was actually taken from a study where they were looking at biomarkers, but they asked some questions of these patients, and they asked emergency attending physicians and residents and advanced practice providers in the emergency department with patients with minor traumatic brain injury. And these are GCS of 13 to 15. There was a subset of about 15% who had some blood, and some got admitted overnight or a night or two, or had a skull fracture. But they asked them, based on the patient that you see now, do you think in 3 months, are they going to be back to their functional state? Are they going to be back to their functional state on and their activities of daily living? And they looked at Glasgow outcome scale. And how are they going to do from a symptom perspective? And then they asked them, how certain are you that your prediction will be right? And what they found, which I think is kind of interesting, in that about 3 months, about half of the patients had not returned to their pre-injury baseline. So I think that's important for us to know that patients with minor traumatic brain injury and concussion, often they don't do well, and they don't do well for a while. But was also kind of interesting, if you looked at both residents, mid-levels, and attendings who were emergency physician attendings, we do a terrible job at predicting this. Our sensitivity was 5% or 8%. So we think most of these patients are going to do well, but a lot of them don't do well. And we also, I think we did a little better in symptoms than in functional, but 34%, that's still pretty bad. And it really doesn't matter if we're attendings or residents. And when we were absolutely sure, we did actually a little bit better, predicting that they're not going to do well. But in the big picture, we are not very good at predicting how patients do. I think that's important when we discharge patients to make clear that, there's a good percentage that may have persistent symptoms. They may persist for months, and making sure that we're letting people know that and giving them the proper follow-up. So that leads kind of the second question is, how well do we do for follow-up? And this is from Track TBI, which is a large multi-center NINDS funded group that is now looking at patients who are minor traumatic brain injury that come in through emergency departments and kind of looking at multiple different things, multiple different outcomes, multiple different interventions. And what they found is that in even the best, so there's I think 17 major trauma, level 1 trauma centers. I forgot the exact ones, but I think it was somewhere, so UCLA, SAA, or USC, Vanderbilt, et cetera. So pretty good trauma centers. And they found that if you looked at how well we did at giving people educational material at discharge, at the best, we were close to 75%. At the worst, we were under 25%. And if we looked at how well we did at giving people follow-up and making sure they saw a provider by 3 months, and once again, at the best, just over 50%. So we do a pretty poor job in the emergency department at thinking about how well people are going to do down the line, and also doing follow-up on these patients. I know at our sites, we're looking at trying to have a dedicated concussion clinic. Internally in the emergency department, we're rewriting our discharge instructions and putting some templates in Epic to make sure that we are capturing the right things and making sure we're going to discharge them right. But this really kind of talks to, we really need to make sure we're getting the right discharges on these patients, because it's not entirely clear what we can do, but there are some patients who will benefit from OT, PT, cognitive behavioral therapy. It really is helpful for patients to know what to expect. And also, if we're trying to do studies down the line, making sure we can follow these patients is critically important. This just looks at the odds ratio of those patients who were seen by a practitioner. And really the take home of this is, and this is looking at that same group that at the best 75% got in, and it looked at things like, what was the injury, how bad was the injury, did they get admitted, did they not get admitted, what was their racial group, ethnic group, what was their insurance, and the take home is that it really made no difference, did not do a good job in any of the patients no matter what. And then there's a little bit more of, who was at high risk. So if you're not going to do a good job, at least can you risk stratify and say, who are the patients we really need to concentrate on? Because it's a much more likelihood that they're going to do poorly. And one was race. Black race was a significant differentiation. If you look at this, the adjusted odds ratio was 5. For probable PTSD down the line. If you look at what happened, and that kind of makes sense, a violent assault was much higher, and if they had a psychiatric history. So those are the high-risk patients by far. There's other ones in there, but those are some really high-risk ones. So one is we really need to do better at letting people know what to do, making sure they get follow-up, and really focusing on our highest-risk patients. And this is just looks at a group where they took a group that came in and they looked at a group that was sent to a TBI clinic, but also sent to patients with orthopedic injuries that came in the same time. And my take home from this, I think, is kind of interesting, is one that, for 6 months, there's about the same of their functional disabilities and their symptoms. But once you get past, these are functional disabilities, once you get past 6 months, it was worse in the traumatic brain injury as persistent problems. But I think this to me, the take home is that, there's a pretty significant number that it wasn't just problems with them and themselves, but it really was some family dysfunction that went on for, I think, in almost 30% down the line, 6 months down the line. So I think if this is something that, as we're telling patients, these are things we need to watch out for, it really is important and useful to bring the family in and let them know that, they're going to be part of this. They're going to need to understand that it's going to affect everyone for quite a bit of time, and they need to be part of the recovery process. So I think with that, I think we're about at time. I want to leave a few minutes for questions and any thoughts. So thank you once again. Hopefully that was interesting and useful. And let me open up. I can't see the chat now if anyone has.
Thank you very much. Yeah, thank you very much. That was excellent excellent overview and excellent talk. I think there's a lot of areas there, like you said, where we could have discussions for several hours if we wanted. Dr. Solucio, there are a couple questions. Dr. Solucio had a question about if there's any kind of data on using TEG or say ROTEM or any sort of platelet assays to guide platelet administration in patients that have TBI that have been on platelet inhibitors.
So my best knowledge is if you look at the TEG and ROTEM data, there's lots of data showing that it works at helping you guide what you do. There's lack of data showing that it shows outcome data. I think that's one of the biggest, questions is can you, it clearly makes a difference as far as probably using the right number, probably avoiding it when you don't need it. I have not seen data showing that if you use it, you'll actually have a better outcome on those patients.
Yeah.
And I think that's not just for patients with head injuries. That's really overall. There's not a lot of great data on that showing that it makes a huge difference. But there is a lot of data showing that it clearly makes a difference on what your utilization is. And it seems like it may be that we're just missing the answer because it does seem like it should be helpful.
Eric, I just wonder whether just the access to TEG and ROTEM, that it's just not available widely enough and in a timely enough fashion that we can actually do this for patients early enough. So I think a lot of the studies that aren't, so perhaps that's one of the reasons why these studies are not able to show any impact on outcomes. I know even at our hospital, so for example, at Mount Sinai Hospital, we're not a level 1 trauma center. And if we want to do TEGs or ROTEMs on patients for other disease processes like aneurysmal subarachnoid hemorrhage, and they have underlying coagulopathies, etc., we're not able to get it done in a timely enough fashion. So any thoughts on improving access to care? Or is it even worth trying to do that?
So, it's a great question. So if you're going to have it, also the question is, where do you have it? So for the most severely injured patients, theoretically, having it in the ED is great, but theoretically you want those patients out of there in 10 minutes anyhow. And so by the time you get the data, you're better off in the OR or in the ICU. But if they're going to be down there, I always worry because in some ways our ratios, especially when you think about nursing and people running it, our ratios are very different than the ICUs. And every time we add another thing in, we don't always do it well, and we don't always do it effectively. And so I think, if I remember correctly, I think Denver has it, and some of the early literature was from out there, and I believe they run it in their ED, and they see a lot of a decent amount of penetrating, but a lot more blunt trauma. And they also see a lot of trauma that is flown in who've had time to develop some of these coagulopathies. So it also may make a difference of where you are and at what point you're seeing the patient. I think, it's hard for me to argue. So I have not argued either successfully or strongly for putting it in the emergency department because I'm just not convinced that the amount of resources we'd have to spend to get it to work effectively are there. It does seem to make sense, even from just a utilization standpoint, that it should be in the ICU or the OR. But as I said, I'm not convinced that we've shown it, but my sense is that we just haven't shown it, but it probably is some benefit to those patients, because it's not just those that are so severely injured that, at this point it doesn't make a difference. You're really dealing with a wide, heterogeneous variety of patients that it probably does make a difference on someone. So that's my thing. Yeah. I saw Devaldo.
So Elmhurst.
So I took this out. Oh, sorry. Go ahead.
I was going to say at all the H&H hospitals, they invested in TEG with platelet mapping. So we have it at all the H&H hospitals. We just started using it at Elmhurst a few months ago. And right now it's kind of protocolized with the massive transfusion protocol to kind of make sure that you've repleted everything at the end. Although we have started using it for, more routinely, particularly in head injuries, but it's not protocolized. And we have it in our central lab so that we can use it from anywhere in the hospital. And they've actually been pretty good about having the turnaround be very quick on it so that it's still useful. But yeah, I think we haven't really used it to guide our platelet administration, although we've started moving away from giving platelets routinely, except when we're either operating or doing an invasive procedure. There's, like you said, there's more data that DDAVP is potentially more beneficial than than platelets just by itself, Yeah. And obviously much less downside to DDAVP too.
Yes, yeah, absolutely. And much. There's a couple of things on here. One about biomarkers. So I actually had that in my previous talk and took it out. I think that biomarkers, so they're used in Europe. There is now an FDA-approved tool, but it requires plasma, and so it's not a simple thing. And it really tells you, it combines a couple of them. I think it's SB10. I forgot that there's 2 or 3. It provides 2 of them. And actually, Andy Jagoda was one of the PIs on it, if I remember correctly. I think it probably is going to be beneficial in avoiding CT scans when used in a specific group. And so one of the problems with the study they just did is that it kind of was for a whole group of patients that some of them we probably wouldn't have gotten the CT scan and been perfectly okay. So I think that incorporating it into a group where whether you're already using some sort of protocol like the New Orleans criteria or Nexus or Canadian, and then saying based on that, they don't fit into the, I can't avoid a CT scan, but let me go ahead and get this, and does it bring me down to low enough? Because there are patients in, say, New Orleans who we have a pretty low suspicion they have anything, but because they have trauma above the clavicles, because they're a little intoxicated, we're still going to get a head CT. So I do think there is some utility for it, especially when you're trying to avoid it in younger people. I don't think it's one of those things we should be doing on all patients. Is there utility for looking at kind of following patients? I'm not sure, but I think it's out there. It probably will be used. It's just not entirely sure, especially in the U.S. where the big study that they published didn't really stratify the patients. I think that's what needs to be done. Hyperventilation is just essentially regional blood flow problems, and so. When you looked at the patients, there was a big study out of San Diego looking at pre-hospital intubation years ago and found that, when they did it, they did worse. And when they broke down the patients of who did worse and why, it really came down to those were the patients who were hyperventilated in the field. And early hyperventilation is probably bad because there's probably some more problems with regional blood flow and causing ischemia. So, and then the question of, is it useful for patients who are essentially about to die, and can you use hyperventilation to prevent it, to cause decreasing intracranial pressure as a temporizing measure? I think we all do it. I don't think anyone knows if it makes a difference. There's such a high risk group. Their mortality is so high anyhow. And there's never been any sort of, as far as I'm aware, any sort of kind of retrospective and clearly no prospective study to say, does it really matter and can you avoid mortality? I think there are some kind of theoretical that because the ICP is so high, you can temporize until you get to a definitive treatment. It's one of the few things you can do. Kind of to me, it kind of lands in the mannitol category in the ED, but it's what the benefit is unclear.
And similar to
I would agree.
the conversation we were having about access to TEG or ROTEM. Similarly, for hyperventilation, if we had a way of monitoring autoregulation or what's happening to regional blood flow while we're actively resuscitating patients, we just don't have the ability to do that. There are some promising papers now on near-infrared spectroscopy in the ICU or using TCDs for monitoring autoregulation. None of that. One, of course, it's not 100% foolproof that we're all going to go ahead and buy these devices and start doing it in the ICU. We still don't have good enough data to advocate for that. And then translating that into the hyperacute, acute care phases down in the ED, or while these patients are getting transferred to hospitals that are going to provide them with definitive care, that's just hard enough. So I don't know how soon we'll have some data to show us that hyperventilation works or doesn't work.
If I go back even to residency, we were talking about TCE back then and talking about some of these non-invasive methodologies to look at this. But if you look, part of the reason I put the hypothermia work in is that was really 20 years to get to an answer, and thousands of patients. And if you look at like CRASH 2 is 26 and CRASH 3 is 13,000. To get these studies done, it is an enormous amount of time and energy, because you're really looking at a difference in a subgroup, and there's so many other things happening. I mean, I think progesterone, everyone thought would make a critical difference, and it just failed. And so I do believe there is somewhere in there that, having better, kind of more patient-oriented for the unique patient does make a difference. But I'm a little bit left with, when I look at today, not a couple of years, is one of the things that I can do. And when I work with residents, they're like, we need to start anti-epileptics, and we need to. I was like, no, you need to make sure you don't hypoventilate them, you don't hyperventilate them, and you don't make them hypotension. And if you can do that, that is the most critical thing we can do down there. And then I think getting to the second level stuff is, understanding what might make difference. I said I use TXA because I think it is probably beneficial, but it's a little bit unclear. And then I think all the others is trying to understand where they're going to fit in to the algorithms.
Thank you.
But starting off, this really is a cooperative venture, because it doesn't make any sense if we're doing one thing and neurosurgeons doing something else. We really have to. And I think we've had lots of great. Even in the last couple of years at West and Morningside, especially, we have a great relationship, and having those discussions is really helpful.
Yeah, we're always, on all our discussions with our residents and everything, we're always saying, the most important thing in any brain injury patient, TBI, ICH, blood pressure, oxygenation. If you can do those two things, and right. Maintaining cerebral blood flow, you've already done better than maybe 90% of places. If you can just keep those, and really it's kind of like the Goldilocks phenomenon. You gotta. I think we tend to, it's really just about keeping patients as close to normal as possible. And if you're already needing to do really invasive things, those patients, we obviously do that sometimes. We need to, but right. Those patients are. Most likely not going to do as well anyway. But so.
Right. But it's like when we hand off the bag the patient to the medical student. I mean, it's like all the things we're doing. We really have to be critically focused on just a few things. I think until we understand what else we can do. Right. I think everyone probably has to go to the next meeting. So I will pop off, and once again, thank you very, very much. I really appreciate it, and it's been great.
Thank you, Dr. Legome. Thank you. Great talk.
Appreciate it.
Take care.
Thanks, everybody. Have a good day.